والمرسلين نبينا محمد وعلى آله وصحبه أجمعين. Good evening everybody. On behalf of Saudi Pediatric Neurology Society, I would like to thank you all for joining us in the first Pediatric Neurology Club in 2021. I hope you will enjoy, inshallah, the scientific content today. First topic will be presented by Dr. Yusuf Al-Yamani and mentored by Dr. Mohammed Al-Muqbil, consultant in National Guard Hospital. It's about Epilepsia Partialis Continua. Second topic, hopefully, it will be with Dr. Fuad Al-Ghamdi, consultant pediatric neuromuscular, about overview spinal muscular atrophy disease and management. And then we will launch the Saudi Pediatric Neurology Society website by Dr. Adina Bahadur. So, Dr. Yusuf, you can start, please.
Assalamu alaikum. I'm Yusuf Al-Yamani, R4 Pediatric Neurology resident. I'll be presenting a presentation about Epilepsia Partialis Continua with under supervision of Dr. Mohammed Al-Muqbil. So it's a case presentation. So the case is a 4-year-old boy who presented to the ER with persistent subtle muscle twitching that does not disappear. Started days ago with no true resolution. The case, of course, was initially under general pediatrics previous days ago for admission with acute otitis media and croup. He was adequately managed with antibiotics and dexamethasone, and then returned back with these abnormal movements. So the history of his abnormal movements, he had an abnormal repetitive movement, mainly confined to his left neck area, that occurs during wakefulness and was more noted during sleep. It started suddenly while he was watching television, as per the mother, and it was not associated with the alteration in level of consciousness. He had no reported history of seizure-like movement or tonic posturing, like signs of clumsiness or early myoclonus. No headache, no difficulty swallowing or facial deviation or weakness or visual changes or hearing changes. So no real focal neurological symptoms. His past medical history, he had a benign maternal history and neonatal course. The past medical history, as we mentioned with their current ear infection, was discharged with amoxicillin and dexamethasone, the last admission, the last presentation to the ER. And he has a developmental history that's significant for language delay. So he's around 4 years old and he's only saying a few words like Baba and Mama, but he uses them distinctively. He has a normal motor and social and personal development, according to the mother, when comparing him to his other siblings. So 2 other healthy brothers and the parents are relatively healthy as well. With initially no reported similar or other neurological complaints in the first or second degree family members. But we'll reveal later on that this was not the real case. So his physical examination, he was vitally stable when initially seen, not in distress, and on room air with just a mild runny nose. His neurological exam was very limited because he was a bit sleepy and not very cooperative. However, we were able to test his gait initially and observed that all his limbs were moving against gravity with the normal symmetrical facial power and full extraocular movements and reactive equal round pupils. His abnormal movement was also witnessed during his presentation, and according to the mother, were persistent for days before. They seemed like contractures that were confined to the left sternocleidomastoid muscle that were sometimes semi-rhythmic, kind of in a waxing, waning fashion, and was also observed during sleep and wakefulness, but no other observed abnormal movements. So I'm going to share a video in a bit. The consent was obtained from the parents to show this video during this meeting, but please, discretion is advised. This was recorded during sleep. as you could see. So these movements persisted, as you mentioned. So initial management investigation for the case, since the history and physical examination initially were very benign, we decided to admit under our service and do a brain MRI, an EEG, a frontal and lateral neck X-ray, an ASO titer, because we also thought this could be a tick, and we advised to continue the oral antibiotics. His routine labs at that time, including CBC, LFTs, and renal profile, and urine analysis were within normal ranges. We did an initial EEG that was reported as normal, and an MRI also that only revealed features of osteomastoiditis with mucosal thickening, but otherwise a normal brain and cervical spine MRI. So we also noted that the patient had, during his clinical course, he responded to some doses of lorazepam that were given. So that was a bit curious, like taking into consideration the fact that the EEG was not having any findings.
Okay, Dr. Youssef, if you can give the first slide, the history or the presentation. And if there is any question, please, if you can write it in question and answer, or if you can raise also hand. Any question about history or examination?
Okay. Do you mean the video or the?
No, the presentation summary. If you can give a summary of the, because there is some latecomer. Yes, please.
So to summarize, his initial history that was obtained was only significant for developmental delay, language delay to be specific, and otherwise his examination was also unremarkable, apart from these contractors that we've shown in the videos. So that's to summarize it as concise as I can. Of course, this presentation was preceded by an acute illness that was determined to be in otitis media.
Okay, and the abnormal movement, if you can.
And the abnormal movement was following the infection, like 1 week following the infection, 5 days before the presentation to the ER. And it was persistent, as mentioned.
Okay, can you please also summarize the abnormal movement or the,
Yeah, to summarize the abnormal movement, I'd say they were regular, semi-rhythmic, waxing and waning contractures of the left sternocleidomastoid that persisted during sleep and wakefulness.
Persistent during wakefulness and sleep. Okay.
Yes. So to get to the initial presentation, we determined it must have been Epilepsia Partialis Continua, which is basically a variant of focal motor status epilepticus, in which frequent repetitive muscle jerks, usually arrhythmic, continue over prolonged periods of time. It also includes non-motor manifestations, noted area, aura continua. So EPCs may occur as a single episode or a repetitive episode. It may be chronic or progressive or non-progressive, and the minimum duration is defined as 1 hour, but it may continue for up to many years. In this case, it was many days. So we have possible etiologies to think about when we first see EPCs. They include Rasmussen encephalitis, mitochondrial diseases, non-ketotic hyperglycemia, and stroke, which we usually think about when in a very acute setting and in the right clinical context. So the symptoms of the motor EPC have been interpreted as a cortical reflex myoclonia, but the pathophysiology is probably not uniform for all cases, as it depends on the etiology. In general, EPC tends to be drug resistant, and epilepsy surgery is often a good choice in Rasmussen encephalitis. Diagnostic workups that we could do in EPCs is usually just to look for the underlying etiology. So it mainly depends on the history and physical examination. And the EEG shows typically a focal epileptiform or slow wave activity that corresponds anatomically to the semiology, but in some cases they are absent, such as in our case. So for our patient, the hospital stay reveals additional information, and this is where I'm kind of gonna take you on a different path from EPCs Um, it was noted that these movements do respond partially to benzos, as you mentioned, which made us think about APCs to begin with. But then the mother disclosed the history of an older female sibling that passed away at an early age of 4 years old. Sorry, I think it was 2 years old, to be honest. But the main presentation of her history was abnormal movements and liver failure, or SATS epilepticus multiple times with liver failure. We obtained the patient's MRN and started looking through her charts. So the history was, as mentioned in the charts, she presented with intractable seizures to the hospital and liver failure with abnormal liver function test and high lactic acid, reaching up to 14 at one point. The patient was thoroughly investigated and family history only revealed consanguinity with the physical exam revealing hemiplegia and ataxia. This is her brain MRI at that point. Maybe the video is a bit too quick, but if you could see in the still image, it's kind of noted on the left side. There was a T2 hyperintense bulky left hippocampus and the focal cortical, that was suggestive of either focal cortical dysplasia or early mesotemporal sclerosis or a post-ictal state. Her EEG at the time showed a diffuse slowing with asymmetry over the left hemisphere and electrographic seizure in the left centroparietal area, with a follow-up EEG showing curious delta and theta diffuse slowing, which we'll talk about in a bit.
Okay, Yusuf, please wait, if you go back, please. Is there any question? Let me see the chat. So at the beginning, is there any workup done to rule out mitochondrial disorder? I think this will come later. So the MRI finding.
The MRI finding initially was it was a normal MRI, but I have later on images of the MRI. So.
Okay. Another question. If you can elaborate more about this movement or classify it. So the walks and weaning, is there any diurnal variation? Is there like it was persistent during wakefulness and sleep, and but is it only specified for the sternocleidomastoid muscle, or is there any other abnormal movement? Could you please?
Yeah, no other abnormal movements were initially during the presentation. He had only the sternocleidomastoid muscle. Even the videos that the mother showed us at home were only the same exact video that I showed you, which were just like rhythmic jerks that are confined to the sternocleidomastoid. And it was almost persistent. Like I would definitely say it was persistent for the 5 days prior to the presentation until he presented and only partially responded to benzodiazepines. So yeah, I would say it was continuous for almost 5 days. It did show some waxing and waning, like we mentioned, is more exaggerated during the sleep periods.
Okay, the level of consciousness, was there any change?
His level of consciousness was normal, even during the initial exam and during the follow-up. His level of consciousness during the initial period of his admission was like normal at his usual baseline.
Okay.
With only the language yeah.
Okay. Another thing, please. Was it progressive or, as you said, wax and weaning? Is another question.
So yeah, initially at the presentation, at the 5 days of presentation, it was waxing and waning still. It was almost the same, like at presentation, at this first day of presentation till the day he presented to the ER. It was, according to the mother, of course, it was the same intensity and frequency, but only with like waxing and waning features that persisted initially for the first couple of weeks, maybe.
Was there any weakness, Dr. Yusuf?
No weakness associated.
Okay. Is there like differential diagnosis? Can anybody give us differential diagnosis of this presentation? Or any further question? Question for you, Dr. Yusuf. Is there any behavioral abnormality?
In the patient who's the sibling, the one I'm talking about right now, we're not really sure, but it was mentioned in the charts that he had like a psychomotor delay. And this patient per se initially had no behavior abnormality. He was exactly as he is at home with only the developmental delay or speech delay.
Okay. Liver enzyme was done.
So the liver enzymes were done. As I said in the initial admission, initially it was normal liver enzymes.
Okay.
Over the course of his stay, or that kind of evolved.
Okay. What about Yusuf? When she presented at the beginning, what was your differential diagnosis?
Well, we thought about tics. That's why we did the ASO titers. We also thought about stroke, an acute stroke. So, but the initial CT that was done was normal, and we went further on for the MRI to see if there's any pathology. So these were the main two differentials we thought about. And then when we started thinking about the entity being an EPC, we started digging more for the etiology. That's how we reached the history of his sister.
Okay, excellent. There is no further
Yeah, thank you very much, Yusuf. Just to be clear for the audience, so we have two overlapping histories now. The first one is about the child, our patient, the index case that presented to our emergency. And the story is building up now. So we are just still on the second day of the admission. So still there is more to come. Now what Dr. Yusuf is presenting for us is what we have disclosed after the admission about more details in the family history. And that is basically the sibling or the sister of this child who passed away. And Yusuf was sharing with us her MRI and EEG, and there is some more to come basically after that.
Okay.
Just to be clear, so that no confusion.
Thank you. Okay, go ahead, Yusuf.
So eventually, with the presentation of this sister that passed away, with the liver involvement and the cerebral involvement with the seizures and tractable seizures, eventually we reached this mutation, homozygous mutation, through a targeted gene sequencing. So this is a POLG1 mutation that was found in a homozygous state in this patient, confirming an autosomal recessive POLG-related disorder. As you could see in this document, does say that this specific mutation does relate to Alpers syndrome as well. So our diagnosis was for the sister was Alpers syndrome, and we started to also work up her brother for that same mutation. So a genetic and metabolic workup was done for the patient, with the basic metabolic studies turning out essentially within normal ranges. So I'd say normal lactic acid and ammonia, plasma amino acid and uric acid, and other metabolic studies like random mass spectroscopy. So Sanger sequencing was then targeted simultaneously with the metabolic studies. And it was sent for target mutation analysis of the POLG gene, or the polymerase gamma gene. This is the result of the Sanger sequence, which reveals also a homozygous variant mutation in the POL gene, which kind of confirms the diagnosis, or definitely that confirms the diagnosis of POLG-related disorder, specifically Alpert-Hunter syndrome, Alpers-Huttenlocher syndrome. So the logical next step was just to test the parents, which their targeted gene tests revealed the heterozygous mutation in the polymerase gamma also. So later on, we started involving more services, and we had different management. They were started on levetiracetam for his movements, and initially they responded well to them, but later on required addition of tegretol and phenobarb. The parents were educated and counseled regarding his case. We involved the genetic and metabolic team. And there was a very good question from the parents that they asked why was his sister's case different than him, although they have the same mutated gene, which is the polymerase gamma, which will hopefully this will answer, this presentation will answer. So these were the services involved. Of course, some of the services were involved later on during the progression of the course. So this kind of reflects how the course of the disease, how the disease progressed in this patient. Genetics and metabolic team were involved early on. Gastrointestinal team was later on involved for transient elevation and transaminases. Also, he had ascites at some point, mostly related to hypoalbuminemia. The ID was involved for his automastoiditis, and he also presented multiple times with the cellulitis and several infections. So they were kind of regularly following this patient with us. Nephrology was involved at some point as well for hypercalciuria. Cardiology just screened him basically with an echo and a Holter that were fortunately normal. And swallowing team was also involved to evaluate the patient for swallowing issues or precautions. Of course, the other supportive management we offered was OTPT and speech therapy. So we'll just talk briefly about the pathogenesis of POLG-related disorders. So this is kind of a schemata of the genes that affect the mitochondrial DNA replication and maintenance. So the POLG-related disorders fall under this category of maintenance and replication of mitochondrial DNA. So it's mainly a nuclear, it's a product of a nuclear DNA that regulates the replication cycle in the mitochondrial DNA, and also has a major role in proofreading the mitochondrial DNA. What you need to know is basically that the mitochondrial DNA differs from the nuclear DNA, that it doesn't proofread all its throughout the whole lifetime of the mitochondria, but rather only when it replicates. So it carries like a 10 times more probability of mutating. So it's normal for mitochondria under oxidative stress to have their mitochondrial gene mutated. So this is kind of another schematic just to describe it briefly. So a defect in the POLG, as we said, it has a relation to maintenance and replication. It will eventually cause a mitochondrial DNA depletion since it can't maintain itself and can't properly replicate. This will affect the complex 1, which is a respiratory chain complex, and it's important for the function of the respiratory chain activity, or as they call it, the electron transport chain. This could either be from a direct pathway like we see in here, or with the compound mitochondrial DNA mutations that accumulate from the initial POLG defect. And this will all cause a progressive loss of respiratory chain activity, which will put a neuronal energy level in a critical phase with a small trigger like the infection in our case. Would cause like a epilepsy that would go into a vicious cycle causing focal necrosis and vice versa. This will eventually lead to neuronal death and apoptosis. So chronic neuronal loss leads to neurological symptoms that we will see further in this presentation, such as ataxia and cognitive disturbances. So the mitochondrial DNA depletion, to talk about it briefly, it's a defect of the mitochondrial DNA maintenance, as we said, and it's due to defective intergenomic signaling, which is a faulty communication between two genomes, to put it simply. The nuclear gene defects that basically alter the biological integrity of the mitochondrial genome, as we said, which leads to the accumulation of mitochondrial DNA deletions. And this is what predisposes the patient to multiple mitochondrial DNA deletions. So another defect of intergenomic signaling is due to a quantitative defect of mitochondrial DNA. Syndromes too that occur due to mitochondrial DNA depletion may affect predominantly one tissue, such as in infantile myopathy or hepatopathy, or multiple tissues, more commonly, such as hepatocerebral syndrome, which is a main classification or a generalized classification that classifies a phenotype that is caused by mitochondrial depletion syndrome and has under it several genes implicated. One of them, most importantly, is POLG, causing Alpers-Huttenlocher syndrome. So the replicated machinery includes the catalytic subunit of polymerase POLG or POL-gamma and the replicative helicase twinkle. So these two units are basically the main factors in replication and maintenance of mitochondrial DNA. So some of the genes that are also implicated, mainly in the nucleotide synthesis, are these genes, SUCL2, TK2, SUCL-GA1, and so on. One of the more important ones is the DGUOK, which also causes a hepatocerebral syndrome, just like POLG. So mitochondrial depletion syndromes are phenotypically classified into myopathic forms that present in early infancy or early childhood with hypotonia, maximal muscle weakness, and feeding difficulty, with cognition is usually being spared, and typically there's a rapid progression of muscle weakness, eventually leading to respiratory failure and death within few years of onset. And there's encephalomyopathic mitochondrial DNA depletion syndromes, which present with hypotonia, so it's a bit similar, global developmental delay, and depending on the underlying defect, it could include deafness, movement disorders, or lay-like presentations, and renal disease as well. There's also hepatocerebral forms, which is the main focus here, classifies as a main category, which includes Alpers-Huttenlocher, and it presents with early onset liver dysfunction and neurological involvement, including developmental delay, abnormal eye movement, and peripheral neuropathy, which initially the patient only had developmental delay and this epilepsy partialis continua, but later on progressed even more. So, and finally, we have neurogastrointestinal forms, such as the MNGIE entity. It's basically presents in adolescent to early adulthood with progressive gastrointestinal dysmotility, cachexia, and peripheral neuropathy. Just to note, the gastrointestinal dysmotility is kind of common with the with mitochondrial diseases in general. So mutations in the polymerase gamma are associated with other mitochondrial disorders involving the gastrointestinal symptoms, muscle, and or CNS, as you will see. And more than 180 pathogenic mutations of polymerase gamma with both dominant and recessive modes of inheritance have been described, which resulted in a wide phenotypic spectrum. It's important to know that they can occur throughout all the exons in the polymerase gamma, produce several clinical syndromes, as well as multiple organ system disease with onset throughout the lifespan, so no specific onset of age of onset. So recessive mutations represent the predominant disease inheritance patterns in these described phenotypes, but some autosomal dominant diseases also were described. We will see. Other mitochondrial DNA depletion syndromes due to mutations in other genes exist. As you mentioned, the hepatocerebral entity or hepatocerebral mitochondrial depletion syndrome can include the genes like MPV7 as a cause, and mutations in the DGUOK gene, as we said, that has a mitochondrial nucleotide synthesis function. So just briefly about POLG, it's a gene encoding the only mitochondrial DNA polymerase known as polymerase gamma. Of course, this has been kind of refuted in a recent study that kind of says that there might be more than one DNA polymerase encoding for the mitochondrial DNA polymerase. So it's still under studying, but mainly classically we know it as the only known polymerase for the mitochondrial DNA. Its location is on chromosome 15, the long arm of chromosome 15 in region 2, band 6, subband 1. So we have also for the phenotype, these phenotypes mainly just depend on where exactly in this gene is the mutation occurring. So the normal gene product has three main regions: the exonuclease and the link region and the polymerase. So the exonuclease is responsible for proofreading the mitochondrial DNA, and the link region, the center of the protein. And there's a polymerase responsible for replication in the last stage of the protein. The pathogenic variants in each of these regions of polygamma have rather distinct clinical consequences. And the clinical features in polyg-related disorders most likely result from depletion over time of normal mitochondrial DNA, with the resultant effect in the respiratory chain or the electron-transport chain activity. So the onset of the polyg-related disorders ranges from infancy to adulthood, as we mentioned. We can mainly describe them as autosomal recessive and one autosomal dominant entity. So the autosomal recessive, we have the Alpers-Huttenlocher syndrome, which is one of the most severe phenotypes and characterized by childhood onset progressive and ultimately severe encephalopathy with intractable epilepsy and hepatic failure. The childhood myocerebral hepatopathy spectrum, which presents between the first few months of life at about age 3 with developmental delay, dementia, lactic acidosis, and myopathy with failure to thrive. And other findings can include sometimes liver failure, renal tubular acidosis, pancreatitis, cyclic vomiting, and hearing loss. The third entity we have is autosomal recessive progressive external ophthalmoplegia, which is characterized by progressive weakness of extraocular eye muscles resulting in ptosis and ophthalmoparesis. And the fourth entity in autosomal recessive disorders is myoclonic epilepsy, myopathy, sensory ataxia, or MEMSA shortly, which was previously described as, or previously referred to as spinocerebellar ataxia with epilepsy. And finally, we have the ataxia neuropathy spectrum, which includes disorders previously referred to as MIRAS and SANDO. And about 90% of people with ataxia neuropathy spectrum have a neuropathy as a core feature of ataxia, and 2/3 develop seizure, and almost 1/2 develop ophthalmoplegia, with the clinical myopathy being usually rare. So usually when we have a patient with, just a note to mention, when we have a patient with autosomal recessive progressive external ophthalmoplegia, we have to watch that patient because he might develop later on features of more Alpers syndrome, so liver involvement and so on. So these patients have to be monitored. So the last entities in autosomal dominant or autosomal dominant progressive external ophthalmoplegia and inherited as autosomal dominant manner with reduced penetrance. That typically includes generalized myopathy and often variable degrees of sensory neural hearing loss, axonal neuropathy, ataxia, depression, Parkinsonism, hypogonadism, and cataracts. So the features raising suspicion for AHS in one literature was listing some features to make you think about Alpers-Huttenlocher when the patient is presenting. So they said the most likely feature is, of course, seizure. And the epilepsy in general is common mitochondrial disease, include all seizure types. Myoclonic seizures commonly reported more than other, but EPCs have also been reported well in mitochondrial diseases. So they believe in this is because the cortex is usually sensitive to this oxidative stress that causes the decrease in energy, the utilization from the mitochondria. So that's why epilepsy is usually a very common manifestation. Other manifestations are hypotonia, developmental delay, movement disorders such as myoclonitis, arthria, keratosis, or Parkinsonism, and also myopathy, including ptosis, ophthalmoplegia, or manifesting as ptosis, ophthalmoplegia, and usually proximal more than distal limb. Other presentations or other signs also could include ataxia, peripheral neuropathy, episodic psychomotor regression, psychiatric illness, and endocrinopathy. And as we mentioned, EPC, which is commonly seen in Alpers-Huttenlocher syndrome, and can result either from structural brain lesion or the normal course of the disease. So laboratory findings that are suggestive of AHS or raising suspicion is evidence of liver dysfunction or failure, which sometimes can follow exposure to certain epileptic drugs. Most famously mentioned to avoid is valproate or valproic acid, but other drugs can also cause this sudden liver failure, liver dysfunction. The other thing we could see is the respiratory chain defect, and the respiratory chain defect can be identified by the enzymatic or polarographic assays, and the mitochondrial DNA depletion can also be assessed and measured. Although we'll get to this later, because it's not very specific or sensitive for POLG, especially in the early stages. So the other thing we have is radiographic features that are suggestive. It could have a CT or MRI that could be initially normal, but later on shows gliosis and generalized brain atrophy. So features that are described in the MRI are regions of increased signal intensity on T2 weighted sequences and DWI, most often in the occipital lobes and thalami, and involving both the cortex and deep gray matter. And these regions often correspond to areas of pathological EEG and may be sometimes absent if the seizures activity is not very active. The other feature, as we mentioned, is a generalized cerebral atrophy. Also in the MR spectroscopy, although not specific, but it may show elevated lactate and reduced NAA peak. And the neuroimaging, as we said, non-specific, but helping in the diagnosis. Other things we can also see in Alpers is T2 hyperintensities in the white matter that are usually symmetric and involving deep cerebral nuclei. But these, as we said, also not specific, can occur in other mitochondrial and metabolic epilepsies, can occur in Menkes and Merv, and can see Lay disease as well. The noteworthy thing is often when the seizures are uncontrolled, the T2 flare hyperintensities are prominent and most likely in the thalami and basal ganglia, more than the other areas. So here are a demonstration of multiple patients with AHS syndrome. And they show different findings. Maybe in the first image, you could see a cerebellar atrophy. In this image, you could see a small hyperintensity here. And in here, you can see also hyperintensity in the cerebellum. And here you can see enlarged olives. This is showing cerebellar diffusion section in the cerebellar region. And this one also showing here some abnormalities. So this is a typical EEG finding in the Alpert-Huttenlocher syndrome. As you can see, the patient suddenly has, down here, if you can see where I'm pointing, it's the occipital lobes. This is a bipolar montage. In the occipital lobe, you could see like a, of course, we can't really comment on the amplitude, but mainly and relatively to the other waveforms, it's a high amplitude, and it's composed of a delta. Of course, it's almost rhythmic, and you could see that it has like an overriding spike or polyspike. So this is a very specific finding, and it's usually associated with AHS or Alpers-Huttenlocher syndrome, and it's called it's RADS, or short for rhythmic high amplitude delta with spikes and polyspikes. So AHS is the classical form of hepatocerebral mitochondrial depletion syndrome, and it's defined as a disorder of childhood by the tetrad of refractory seizures, episodic psychomotor regression, cortical blindness, and hepatopathy with micronodular cirrhosis. It can be caused by a homozygous or a compound heterozygous mutation in the nuclear gene polymerase gamma or chromosome, as we said, long arm of 15, chromosome 15 with region 2 band 6 subband 1, that encodes the mitochondrial DNA polymerase gamma. The onset of this disorder is usually between 2 and 4 years, as you mentioned, and the range can go up to from as low as 3 months to 8 years. With some studies showing a peak incidence, another peak incidence at around 17 to 24 years of age, so a later onset. So seizures and movement disorders are the most dramatic central nervous system symptom of AHS, and it happens in about 50% of the patients. So it's a very frequent symptom. And this is talking about initially during the presentation, but I'm not sure of this, but I believe the progression of the disease will eventually cause seizures and movement disorders. So once seizures appear, the tempo of the disease becomes rapidly progressive. So once the seizures start, it's kind of a progressive course from there on. And it's good to note that some patients have the febrile convulsions or initially just present with the febrile convulsion. So another thing to note is a focal asymmetric occipital predominant seizure usually present as a visual or tactile hallucination with nausea and vomiting, dysautonomia, headache, and nystagmus auras and/or seizure. And they're often to come together with focal and/or generalized motor seizures. So a lot of times the EPCs can occur with aura continua, like we've seen before. So a thing I might have failed to notice, to mention, is that these clinical phenotypes are usually related to which part of the gene product is mutated. So that kind of explains partially why the phenotype is usually different in this disease. So as we said, during the initial period of EEG, during the initial period of seizure manifestation is often with occipital predominant discharges. And as similar to the morphologies that we mentioned, the rats. So as the disease progresses, most patients have repeated episodes of SATS epilepticus, epilepsia, or Partialis, Continua. In some instances, the first seizure type is EPCs, and the EEG, as we said, may be normal or only show focus slowing in the background rhythm. Myoclonus and myoclonic seizures become more prominent and become almost continuous, and both are refractory to medical treatment. It can be difficult to distinguish from EPCs or seizures, myoclonic seizures. The seizures and the lack of effective medical control is a major morbidity in these cases, and death due to uncontrolled seizures is commonly seen. And medically intractable seizures produce hippocampal sclerosis. Maybe this is similar to his sibling's case, where they have evidence of like a hippocampal sclerosis on the MRI imaging. So as you mentioned, the primary myoclonus and choreoathetosis are common in these patients. Palatal myoclonus also may occur, but this is usually when the inferior olivary nuclei is involved. And Parkinsonism can also be seen sometimes, like it's kind of like the presentation of specific hemiplegia and the autosomal dominant. So this is important to note because a lot of these phenotypes that we described have an overlapping presentation a lot of times. So another presentation or clinical manifestation is neuropathy and ataxia, which develop in all people with Alpers-Huttenloch eventually. They also could have areflexia that results from neuropathy, and the hypotonia that is possibly a result of generalized weakness and also with a combination of systemic illness and possible pyramidal or expyramidal dysfunction. Cranial nerve dysfunction and abnormal eye movements are often both present early in the disease course. And ataxia can be an early symptom and is usually universally seen during the course of the disease. They say it could be due to cerebellar, sensory, or cortical involvement. So it's either maybe a sensory ataxia or weakness related to actual cerebellar. So the evaluation of the children with neuropathic ataxia is a bit difficult, but in older patients with POLD mutation, sensory peripheral neuropathy was demonstrated to be due to the loss of peripheral axonal branch of the dorsal root ganglion neurons that is secondary to the neuronal death. So it is hypothesized that the same mechanism likely occurs in younger children. Sensory neuropathy has also been reported as a very early finding. And as you mentioned, the cerebellum could be involved in this disease, but it's very involved, often with Purkinje cell involvement and preserved granular cell layer. So the degree of ataxia kind of correlates with the cerebellar loss of Purkinje cells. The other manifestation is a visual loss. So visual loss is mainly caused because of the predominant neuronal loss in the calcarine and striate cortex. And they present as clinically as blindness. It may be transitory, but later on becomes more permanent with the disease progression. And retinopathy or retinitis pigmentosa can play a less important role in vision loss. Sometimes hearing loss occurs, but it's very variable.
Okay, Yusuf, 5 minutes to room for questions.
So I'll just gloss real quickly over the clinical presentation. Can include, as we mentioned, episodic psychomotor regression, loss of cognitive function, which also can be exacerbated by the antiepileptic medication that affects the patient's cognition, as well as the seizure and the course of the disease. Some other features to put in mind is that can also present before the initial presentation of the patient. So usually they're written off as like a minor issue, like migraine headache or clumsiness or progressive ataxia. But later on, they could also develop these, especially migraine headaches with visual hallucinations, and mainly due to occipital lobe involvement. As we see in this disease, it has a preponderance to affect the occipital lobes. Stroke and stroke-like episode may also occur. So the diagnosis, we need for diagnosis of POLD-related disorders, we need to identify biallelic POLD pathogenic variants for all phenotypes, as we did in this case, where we tested the parents and they both had a heterozygous mutation. So what we need to know is the mitochondrial DNA copy number in AHS syndrome is usually 3 to 40% of normal, which explains the name mitochondrial depletion syndrome. Of course, respiratory chain enzyme testing and testing for count of the mitochondrial DNA would not be that helpful, as and other tests as well, brain MRI and EEG would not be helpful in diagnosing or confirming the diagnosis, since they're not very specific and they can, early on the disease course, they can be normal actually. That also applies for the mitochondrial depletion. Which sometimes is not evident in some of the mitochondrial deletion syndromes or specifically in AHS. So sometimes we don't see the deletion, some case reports. So it's not a must to see it. It doesn't exclude the diagnosis if it's not depleted. This is just a table to summarize the criteria for diagnosis. Before we went on with the follow-up MRI and EEG, we had like multiple evidence here. And even before the gene sequencing, we had a sibling with AHS and the EEG showing this later on, the brain MRI also showing some findings later on. And they had refractory seizures, but we didn't see the hepatopathy early on the disease. So histopathological changes in the brain, usually microscopic changes like spongiosis, neuronal loss, and astrocytosis in the cortex that eventually go deeper into the deeper cortex. Early in the disease, there's central volume loss and can give the appearance of hydrocephalus ex facto. And in the terminal phase, the cortex becomes a thin gliotic scar with the resultant cerebral atrophy, and in a lot of cases, cerebral atrophy as well. So the management will need a multidisciplinary approach. Family need to be educated about the course of the disease, the fact that we might sign a support code or a no code, ventilation requirement and possible CPAP requirement, gastrostomy, feed tubing, tube feeding, and OT and PT. Also, we will require antiepileptic drugs to control the seizures, and vitamin cofactor therapy have been recommended in Alper's Houghton Locker, especially folinic acid and levocarnitine can be empirically used, especially in Golgi-related disorders, because they've noted secondary deficiency in folinic acid. Otherwise, we treat the other manifestations that might occur, like respiratory and GI and hepatic complications accordingly, and supportive therapy. Anti-epileptic, there's no evidence between the old and new that one is superior, but some say the new are better because less side effects, less hepatic effect, and more tolerance. And usually we recommend to avoid the phenobarbital phenytoin as they might also affect the liver enzymes, the liver function. Some unpublished pathway said that we could use a regimen of lamotrigine and then lacosamide and clobazam finally if the medication is no longer effective. So symptomatic management of the movement disorders, we can use benzodiazepines. It could be both relaxing and also resolves or manages the movement disorder. Also, dopaminergic medication can be used like levodopa or tetrabenazine. Some studies were made on these, and in our case, we used haloperidol because the patient eventually developed choreoathetotic movement, and it was effective. He was discharged with the oral risperidone.
Okay, 1 minute, Yusuf.
Okay. So the management of liver failure is not recommended, recommended, and it's usually with the policies of glucose and feeding and managing the side effects mainly. But transplantation has not been recommended because the CNS progresses regardless of the liver transplant. In some adult cases, it is implicated. So this is just for any mitochondrial emergency, just to give dextrose and lipids and correct metabolic errors, avoid medications like valproic acid, statins, metformin, and some antibiotics, and to repeat neuroimaging whenever acute changes occur. So there was one study in treating in mitochondrial epilepsy in a case 26-year-old that was eventually controlled only with Keppra and the low glycemic index treatment diet, which is like a variant of ketogenic diet, and she showed good control of her symptoms. So genetic counseling should be provided, and family planning should start before pregnancy, with also DNA banking being important in any case where it's undiagnosed or the diagnosis is still not confirmed. Because we might have later on more insight into diagnosis. This is just, lastly, I'll just touch on this. It's a novel treatment that has been tried in mice, and it's an epilogue or called EP743 for benzoquinine that showed some promise in mice with polio-related disorders. So follow-up investigations are required just routinely, and recommendations are basically liver function and routine labs with metabolic metabolic workup and liver ultrasound with EEG and other investigations that deal with the emerging consequences of this disease. So the disease progression is usually variable in timing and rapidity, and usually it ends in neurological function, loss of neurological function, dementia, classic quadriparesis. The expectancy from initiation of symptoms is 3 months to 12 years life expectancy. So The other thing is this variable presentation and disease progression could be related to medication use, like valproic acid and phenobarb. It also could be related to the location of the POLG mutation, as you mentioned before, and a lot of other factors. Just to summarize, sorry, I'm just going to take one extra minute. The clinical course of our patient, he was discharged initially with the epileptic, and then he came back multiple admissions in the PICU with the myoclonus and the refractory seizures. He did an MRI at one point after he developed cholecystosis and was suggested cerebellitis. Was treated with both antibiotics and haloperidol. These were the choreoathetotic movement that he developed. And this was his MRI, if you could note the hyperintensities here. This was his MRS at that time. Okay, just to compare, this is the MRS of the basal ganglia. This is the right matter. These are the ones we have here. You can see that the peaks of the choline protein are a bit high. This was his EEG. I just really wanted to show you this one because it's very typical rats. As we said, high amplitude, delta slowing, spikes and poly spikes. He had some fast activity also, superimposing.
Right.
He also did the VEP and ERG that were with normally IRG and abnormal VEP, which satisfies the criteria. And this is the medication he was kept on before discharge. Of course, with the last category being more of a supplementation and vitamin. So take-home messages to recognize you have to have a high clinical suspicion, and it demands an early empirical management with proper avoidance of specific medication, which valproic acid mainly. The best approach to quickly confirm diagnosis is just to send to the targeted gene mutation, especially if there's a suggested family history. And it always requires a multidisciplinary team approach. And please always obtain verified medical history, especially the family history in such cases. And inshallah, there is always hope. Thank you so much, and I'm sorry for taking too much time.
Thank you, Dr. Yusuf, and thank you, Dr. Muhammad, for this excellent, thorough presentation. It was great. I will just go over the question, just 2 or 3 questions. Quick answer, please, Dr. Yusuf. Did this patient receive the coenzyme Q10?
Coenzyme Q10 per se, although it is recommended in multiple papers to supplement, but this patient specifically was not provided with it.
Okay. Dr. Muhammad, do you think is there any help, coenzyme Q10 or other vitamins?
Yeah, thank you very much, Dr. Absaad. So I think basically in this case, sometimes they will have secondary deficiency. So CoQ10 actually supplement is not actually one of the standard of care. As you know, it's only indicated in those with a primary CoQ10 deficiency. And actually in those cases also, some of them will not respond. The only thing that we tried it in this patient, they might have secondary cerebral folate deficiency, as we see in those patients with Rett syndrome or with serine biosynthesis defects, which we actually already started on him on folate and folinic acid along with the other mite cocktail, but unfortunately he didn't show any improvement or any change in his clinical status.
Thank you. Initially, Dr. Yusuf, the patient was tried, I think, Integritol. What was the response? Was there increased seizure or?
Sorry, initially the patient was started on Keppra.
Okay, not Integritol. Okay. طيب, thank you, Dr. Yusuf. Thank you, Dr. Muhammad, again for your excellent thorough presentation. Now, we will take a few minutes, 5 minutes. Dr. Adina will launch the Saudi Pediatric Neurology Society website. Then after that, we will go to Dr. Fuad Al-Ghamdi for the second topic today about the SMA management. Dina, Dr. Adina.
Assalamu alaikum. Can I share my screen?
Yes, please go ahead.
طيب, Bismillah ar-Rahman ar-Rahim. Now with the pandemic of COVID-19, we have to stay home and we have to stay safe. So at the Pediatric Neurology Society, we find a home finally for all of us. And this home is the website, our website. Regarding our website, we dedicate this website to all pediatric neurology and all neuroscience people and other people like the community service. We have part discussing the community issues regarding pediatric neurology, and to parent and to find a pediatric neurology doctor. So I hope you will enjoy our new website. And if you have any comments, you can contact us at any time. This will be your home for all of you. I hope you will stay safe at your home and enjoy your stay. Thank you.
Thank you. I think also our partner, Ibn Troub, thankfully would share this, the link of this website to the attendees. Okay, so the second topic will be with Dr. Fouad Al-Hamdi, pediatric neuromuscular specialist from King Fahd Specialist Hospital in Dammam. Without further delay, please, Dr. Fouad.
Thank you so much, Dr. Saad, and also I want to thank the Novartis Gene Therapy and Pediatric Neurology Society for giving me this opportunity to present. I'm going to speak briefly about the overview of spinal muscular atrophy disease, treatment and landscape. In the last few months or the last 1-2 years, we heard a lot about spinal muscular atrophy because we know it's we have a lot of progression on this disease and the medication. Before I start, I want to announce that Novartis Gene Therapy is doing refreshment lectures in the coming few months. So I will start with the overview of spinal muscular atrophy. And in a few weeks also we'll have another lectures, and we will go through about the guideline of managing spinal muscular atrophy, the gene therapy, the local experience, international experience, and also the clinical trials over the coming few months, inshallah. So let me just remove this. So when we talk about spinal muscular atrophy, we need to know that the treatment option that we have and how to diagnose spinal muscular atrophy. So when we talk about SMA, SMA is not a new disease. SMA was discovered more than 130 years. And it took us more than 125 years from the first report till the treatment, the first treatment we have. So over the last 4 years, and since 2016, we have 3 approved medication. We have one, the Nusinersen in 2016, and we have the gene therapy in 2019, and we have the risdiplam in 2020. So why we have an SMA? What's the difference between someone who is healthy child and someone with SMA? If you look to the upper part of the screen, we have the unaffected individuals. So in those normal people, usually we have SMN1 gene and SMN2. And the only reference for the SMN protein, and I want to pay your attention here that we are saying SMN1 gene, SMN2 gene, and SMN protein. So 3 different things. So we have, for the SMN protein, we have 2 sources. We have the SMN1 gene and we have the SMN2. And as we can see, from SMN1, we got a lot of SMN protein, the circle in blue, the rounded shape in blue. And from SMN2, we only get a little amount or small amount of SMN protein. So in order to have a normal nervous function, we need to have an SMN protein. So what's happening in affected person, and someone with SMA, we don't have the main source, the SMN1 protein. It's deleted. The gene is deleted. The SMN1 protein gene is deleted. So So we only live with the little amount that we got from SMN2. And as much as we have more copies of SMN2, we will have a milder phenotype or a milder symptoms. So when we have more SMN2 copies, we will have milder symptoms. So SMN protein is a very crucial protein for the nervous system. It's mainly working in the acetylcholine receptor and the transmission of the acetylcholine. So when I have a deficiency, I will have a problem with the acetylcholine function. We know it's an autosomal recessive disease. So usually when you have a child, affected child, we expect to have both parents are carrier in most of the cases. But what's happened sometimes, when we get a affected child, and we screen the dad and mom, we find someone carrier and the other one is not carrier. And what I want to say here, I need to highlight that sometime we have a rare phenomena which we call it 2-0 SMA carrier. So the one you see here, I point to the mouse, the one in the left, this is the typical carrier that we see. So we have 2 copies or 3 or 4 or 5 SMN2, but we have only 1 copies of SMN1. But if you screen this person, the one on the second one, on the right side here, so if you look to how many SMN1 copy you have, you will get he has 2 copies. So the report will interpret it as he is not a carrier. He is a healthy individual. But in fact, he is a carrier. This person is a carrier. He has, yes, 2 copies of SMN1, but both copies in 1 allele, in 1 chromosome, and the other chromosome there is 0. So the child has a chance to inherit the one with 2 copies, or also has a chance to inherit the one with 0 copies. So the message here, sometimes you do a carrier test for the parents, and you get 1 healthy, 1 carrier. The healthy one is actually, he's a carrier, but he has both copies in 1 chromosome. This is very important, and usually it happens from 3 to 5 to 8% of the community. In my patient, the data I have, 15% of my patients, they have this 2-0 SMA carrier. So what's the incidence of SMA? Internationally, we say it's 1 in 6,000 to 1 in 10,000. Some local studies, it goes like up to 19 per 10,000, which is extremely, extremely high. But even if you look to the international, if you compare to the international, or you consider the international data, it's high incidence, like 1 in 6,000. And definitely in Saudi Arabia and other Gulf states, it's higher than international data because of high consanguinity. So how many types of SMA we have? We have like 5 different types, but the main types are the 3, type 1, type 2, type 3s. And usually we don't classify them based on how much or how many copies of SMN2 protein they have. We classify them based on how much they can do, what's their motor achievement or acquisition. So usually type 1, they never sit by themselves independently. So we ask the family, can the child sit by himself, not pulling the child to sitting position, but can the child sit by himself? If he cannot, this is type 1. And type 2, they can sit by themselves, but they cannot stand and walk independently. And type 3, they can walk independently, and after that, they develop the weakness. And as we said just a few minutes ago, when we have more copies of SMN2, we have milder symptoms. So usually type 3 and type 4, they have more copies than type 2, and type 2 has more copies of SMN2 than type 1 and type 0. So what's the main feature? The main feature, as we said, or the main parameter that we differentiate between the different types is how much the child can do. But also we need to know that the most common type is type 1. Type 1 is the commonest type. It's almost 60% of the kids they have, or children, they have type 1, then type 2, then type 3. And we already mentioned the main feature of differentiating those types. So what's the main presentation, especially of type 1? As all of us, we know that usually they are hypotonic, they have proximal weakness, they have neck lag, delayed motor development, they have tongue fasciculation. So if you look carefully to this child, the first thing you will notice that this child is very attentive. He's very interested to surrounding. He's looking around. So not like the other patient we see, for example, in congenital muscular dystrophy or myotonic dystrophy. Those people, they are usually dull. They are not interacting with people. Most of the time, they get immediate intubation. So this child was very interacting with people. The second thing, you see that he's moving the distal part. He's moving the fingers and the distal part of the arm and feet, but rarely he moved the proximal part. As we can see, he's starting lifting the arm now up, but he's not like the other, the normal child where they are usually moving the hand above against the gravity and also the feet. The other things that we usually see in this child, it's not clear here. I'll show another video, which is the paradoxical breathing. We are using the abdominal muscle to breathe, not the chest. I'll show another videos. And the other things is the tongue fasciculation, as we see here. Usually they have tongue fasciculation. So those are very important signs. Once you see it in any child, you have to think about SMA. So hypotonia, proximal muscle weakness, the abnormal breathing or paradoxical breathing, fasciculation. This is always like the top diagnosis is SMA. Here, another video, we see that he is able to move the distal part, but he cannot lift the arm against gravity. So proximal muscle weakness. Again, this is SMA. And here we can see what I mentioned is the paradoxical breathing. Look to the chest. He has the chest, the bell-shaped chest. He has very atrophied intercostal muscle, and he is using the diaphragm and abdominal muscle to breathe. Just look to the videos. He is using the abdominal muscle to breathe. He's not like expanding the chest in and out for breathing. This is also another SMA, but this is type 3 SMA. You can see that he's able to stand by himself and he's able to walk, though he has mild Gower sign in this video. And Gower sign is indicating proximal muscle weakness. It does not indicate Duchenne, because some people think once we have a Gower sign that it goes with Duchenne. No, it can come with any proximal muscle weakness. So what's happened with type 1 SMA? What's happened with type 1 SMA? They die. So only 8%, they survive 20 months if we did not treat. So that means we have to try to diagnose early and we try to treat early. Otherwise, we're gonna lose the child if we did not treat. So when to suspect SMA? We suspect SMA when we see the sign that we just mentioned: hypotonia, proximal muscle weakness, abnormal breathing, paradoxical breathing, the bell-shaped chest, depressed reflexes, tongue fasciculation. Once you have it, always think on SMA and keep it in your top of differential diagnosis, because it could be the only treatable disease in this age, in addition to the congenital myasthenic syndrome. But usually, if it's congenital muscular dystrophy or myotonic dystrophy or any of the other neuromuscular diseases in this age, usually it's non-treatable. So always consider it as top of differential diagnosis, especially when you have a family history or you have a sibling with the same disease. So SMA is not the only disease. We can have congenital myotonic dystrophy. We can have syndromes like Prader-Willi syndrome, congenital myopathy, congenital myotonic congenital muscular dystrophy. So different manifestation, and sometimes we use the lab to differentiate between it. Sometimes we use the nerve conduction EMG, and sometimes by just looking to the child, looking to the dysmorphic feature. So, but the most important differential diagnosis is SMA and congenital myasthenic syndrome. At least we can offer something, we can treat the child. So we always have a delay from the time of diagnosis or time of presentation to time of diagnosis. So type 1, usually there is a 4-month delay in diagnosis. Type 2 and type 3, almost 12 months. This is very crucial, especially for type 1, because time is nerves in type 1. Every day we delay the diagnosis, we lose nerves, we lose motor skills. And as we know, when I diagnose early, I start treatment early, the prognosis is much better than start late and diagnose late. And that's what's happened with the SMN1 and with SMN protein and the nerve, like maintaining the nerve function. If you look to the type 1, usually they have only few nerves. The one, the bottom here with the dark blue, they have only few nerves that's still surviving, still functioning. And we're gonna lose it quickly if we did not start treatment. And type 2, they have more like functioning nerve, and they're gonna lose it if we did not treat. And type 3, they have like more surviving motor neuron, but if we did not treat, we're gonna lose them also quickly. So it's very important. For example, if you have someone with type 1 and we have only 50 like motor units survived, I want to maintain this. So I want to diagnose it early and start the medication as early as possible. So what medication we have? How many medication we have? We have till now 3 approved medication available in the market. So we have Avexis 101, which is like Novartis, owned by Novartis. This is the only gene therapy available now for SMA. It's only one time per life. We give it intravenous. And the main idea of this, instead of like as we said, the only source for SMN1 protein is SMN1 gene and SMN2 gene. The main source is SMN1. So we don't have SMN1. What's happened with this medication, they create SMN1 in the lab, and they just give it through the virus vector to the blood. So we create the gene outside and we give it to the affected child. So the child will generate and will produce the SMN1 protein. It's only one time per life. We give it IV and it's approved for less than 2 years in the United States, but in other countries, they have different different ages we're gonna talk about. So this is the first one, and it's the only one, the gene therapy, and it's the only one that gives once per life. So also we have the nusinersen, and we have the risdiplam. Both of them, they work in they trying to convert the SMN2 gene to SMN1 gene somehow, so they can produce more of SMN protein. So we have the nusinersen, we give it intrathecal, and we have good experience in Saudi Arabia about nusinersen. And as we know, we give like 4 loading doses in 2 months, then we give 1 dose every 4 months. And the other medication, it's oral medication, which is the risdiplam. It's an oral medication, small molecule. We take it once per day, and it's also lifelong. So for the gene therapy, in the United States, it's approved for anyone who's less than 2 years. In Japan, it's approved for everyone who's less than 2 years. But he has negative antibody against AAV9, which is adeno-associated virus 9. And in Europe, it's approved for anyone who's type 1 or anyone who has less than 3 copies, even if more than 2 years, not like in the United States. So if I have someone who's like 2.5 or 3 years, and he has only 3 copies, and he is in SMA confirmed by genetics, still he can take it in Europe. So, as we said, in gene therapy, what they do, they create the whole gene and they put it inside the system, inside our body. But what's happened in nusinersen and risdiplam, they go to the point of that make a difference between SMN1 and SMN2. So if you look to the gene, SMN1 gene and SMN2 gene, it's almost identical genes. They are almost identical. There's only one point where it's make the difference. It change, like make the difference between SMN1 and SMN2, and it's usually in exon 7. So what's happened, the molecule that they create, it goes to that site and try to modify it from, so the outcome of like the look of SMN2 will look like SMN1. So it will produce more amount of SMN protein. So in gene therapy, what we do, they took the virus vector, they put the gene inside it, and they give it to our body, and our body will maintain the gene, but will not maintain the virus. The virus will like disappear, die and disappear from the system. So we will only keep or maintain the gene itself, and the gene will generate the SMN protein. So to conclude, SMA, it's a common disease, especially in our area, in Saudi Arabia and other GCC country. It's the leading cause of neuromuscular diseases, like leading cause of death, as well as a neuromuscular disease. It's the most important, the most common neuromuscular disease that cause death, especially in the first year of life. Usually they deteriorate very fast and they require ventilation, especially type 1, if you did not treat. Still, we are unmet medical needs for the treatment, the multidisciplinary clinics and approach still unmet in our region. And we have different medication available, and now a lot of other medication coming in the way soon, inshallah. And Avexis A101 is mainly used for SMN, for SMA, confirmed SMA, and anyone who's less than 2 years. And also, if you want to follow the Europe, anyone who has less than 3 copies of SMN. Thank you so much.
Thank you, Dr. Fahd. Excellent presentation as usual. I have a question here, Dr. Fahd. Why they approve in United States the biallele mutation, and in Europe they approve it for both? Is there like difference in response to the treatment?
No,
or do they respond to the biallele more than
actually they approve it like the genetic in both, it's the same. So
yes.
we have to have a genetic deletion or point mutation, but we need to have a confirmed mutation in both allele, which is the same in both. But the difference is in the United States, they approve it for everyone who's less than 2 years, regardless of SMN copies, and regardless of the type of SMA. So he could be type 1, type 2, type 3, but the most important, he's less than 2 years. In Europe, they give it more space, so anyone with type 1 or anyone who has more than 3 copies of SMN2, less than 3 copies of SMN2, 3 or less.
Okay, another question. Is it possible to give the gene therapy to patient SMA with another immunocompromised disease, or it never?
Theoretically, I think yes.
Okay.
The virus vector is not a live virus, so we don't anticipate that the virus will multiply and like grow inside the bodies. So the virus is just we use the shell or the capsule of the virus. So the virus is not a live virus, not like attenuated virus or a live virus. It's just like we use the shell, the structure of the virus, just to deliver, but it's not a live virus. So we don't expect that the virus will multiply inside the body. The other things, when we give this medication, we give steroid.
Okay.
So we give steroid for just to manage the side effect, not for the virus itself. But also we don't see like any complication from like suppressing the immunity by giving a steroid.
Okay, another question from Dr. Mubarak. Is it available in Saudi Arabia?
The gene therapy, we have one patient got it here in Saudi Arabia, one patient got it abroad and came back to Saudi Arabia, and we got it here, inshallah, in the coming series.
It's available, yes.
Yeah, but it's not widely used.
Yes.
Not yet widely used.
Last question, any potential plan to include the SMA test in newborn screen?
Actually, we wish to start this. I know some of my senior colleagues, Dr. Salman, Dr. Mehazer, we discussed this before, and they have some initiative to start this. I think we should have it. I don't know where are we now exactly, but I think we should have it. And just you remind me about one thing, that we can do genetic tests. Like if you are working in periphery and you have no access to do genetic tests in your hospital, there's different companies doing genetic tests for free. So we can reach them out and do it for free.
Okay, another question from Dr. Hiba Qashqari. What is your experience with epilepsies in Saudi Arabia? As you said, one case was received, he received here, and one in state abroad, I think. And what is the wait time to get the approval?
It's a process that we submit paper to Ministry of Health, a committee there, they study it and they reply back to us. It takes sometime few days, few weeks. The local experience will be presented in the coming lectures, like our colleague will present their experience with gene therapy in Saudi Arabia in the coming lectures, like in the coming weeks.
Okay, excellent. Thank you, Dr. Fahd. Thank you for excellent presentation. Okay, at the end, I would like to thank you all for attending our first Pediatric Neurology Club meeting. Hopefully we'll see you in the next meeting. And at the end, I would like to thank also Gym Farm, Novartis for their support, and also Event Troop for organizing this activity. Thank you all.